All right, well, let's get started. Thank you everyone for joining us today for our PASU Grand Rounds. Here's a slide showing the PASU National Classroom. This is a website where you can access a lot of resources for pediatric environmental health. And my name is Dr. Sarah Watkins, and I would like to welcome you to today's Grand Rounds presentation. We're hosted by the Southwest Center for Pediatric Environmental Health, which is one of the 10 pediatric environmental health specialty units, also known as PASUs in the United States. The purpose of the PASU program is to serve as a leading national source of medical information and consultative advice on environmental conditions that influence human health throughout reproduction and pediatric development. To serve part of our mission, we offer this Grand Round series once a month on the third Thursday of every month. And we are grateful that you have joined us today to hear Dr. Geoffrey Smelski speak on rattlesnake envenomation in the Southwestern U.S. Before we get started, I just want to make you aware of some housekeeping items. So you will not be able to share your video during the WebEx event. You will be muted just by default when you join, and you cannot unmute yourself. But to ask a question, we'd love to have questions at the end. Please type your question to the host or the panelists during the event using the Q&A panel on the right side of the screen. And we'd like to thank all of our partners at the US EPA, the ATSDR, and the American Academy of Pediatrics, without which we would not be able to do our work at the PASU. We would also like to thank the TTU HSC El Paso CME department for making both CME and CNE credits available. Each registrant has to log in with the registration ID to track their login, and that will allow us to provide your CE credits. And please, if you want credit, stay on the call for the entire presentation. And then everyone who is seeking credit must request their credits after they complete the post-test and survey. And you can scan this QR code for CME credit. And if you need that code at the end, we can always email it out. Just a preview for next month, our next Grand Rounds will be on Thursday, December 14th from 11 a.m. to noon Mountain Time on ethylene oxide exposure, presented by Dr. Boron, Stephen Boron, MD, who's a professor here of emergency medicine and medical toxicology. And you can use that QR code to register, or you can sign up for the email brochure. Okay, so getting started. Without further ado, the Southwest Center for Pediatric Environmental Health would like to welcome Dr. Geoffrey Smelski, PharmD. He is he's the Clinical Education Director at the Arizona Poison and Drug Information Center. He's a licensed pharmacist and board-certified toxicologist. He, in his current role, he serves as the Fellowship Director for Clinical Toxicology, and then also for a new Public Health and Envenomation Research Fellowship. We're very fortunate to have him with us today. He's my friend. We were co-fellows together. I'm really happy that everyone gets to hear him speak on rattlesnake envenomation in the Southwestern U.S. And with that, Dr. Smelski, we will give you presentation mode and take it away.
Fantastic. Give me one sec here to get my screen sharing working here. Okay, is the appropriate screen sharing now?
It all looks correct. Go ahead.
Perfect, awesome. Thank you for the great introduction, Sarah. And with that, I will kind of dive in. Thanks for having me today. So again, I'm based out of Tucson, Arizona, and our poison center here covers a little over 60 hospitals around the state of Arizona. We cover all except for one county. So a lot of the information I'm going to share is going to be specific to Arizona, although it is likely very applicable to a lot of the regions across the Southwest in the U.S. So just kind of my little disclaimer about my own limitations and things. And with that, I will kind of dive in. So we break kind of snake bites and their public health burden into a couple of different areas. So we'll talk about some basic science things. We'll talk about the public health role with regards to preventing snake envenomations in the first place. One of our great missions as poison control centers is just prevent the problem altogether. We'll talk about some pre-hospital interventions. We'll talk about some inpatient stuff, and then we'll talk about some of the outpatient complications that we've been researching lately. So I talked to a lot of different audiences about this, and I can talk for way too long about it. So I'm going to try not to do that today. I'm going to try and keep a pretty quick, steady pace going through and be happy to answer a whole bunch of questions at the end. I do usually give this lecture live, and so I do have a couple of questions kind of to the audience in here that I'll kind of pause, give people a chance to think about. Maybe they can put their answers to it into the chat, and then I'll advance to the answers to the questions just as a heads up. So with that, we'll kind of dive in. So folks love pictures, and there's lots of snakes in Arizona for sure. So I'm from New York, where this is not really a problem, but I've been living here for about 6 years now, and I've become a whole lot more familiar with it. So just some of the things that are out there just to kind of get folks awake this morning. As far as what we see. And so kind of some key features of a rattlesnake in the first place. They have this triangular head. They have these elliptical pupils, these heat sensing pits, which kind of give them a predator type vision. These fangs are kind of one of the classic hallmarks of knowing a pit viper and the forked tongue, and they have a rattle. Most of these features, if you are close enough to see them, you are probably too close to the snake. The rattle kind of being the big exception to that. And so some kind of basic biology about the life of a rattlesnake. Most of what they do is they just try and avoid their predators. They're quite fragile little critters. Most things can step on them and crush them. And so a lot of what they do is they hide, and then they kind of are just this ambush predator waiting for their meal to essentially walk in front of them. The big thing that comes up in their life that they do, where they do choices that they wouldn't otherwise do, like other species, is in the name of mating. And so during their breeding seasons, we see snakes going places they don't know, they wouldn't normally ever go to. And we kind of run into this snake and human encounterings. A lot of things will influence whether or not they decide to do that. A lot of it's temperature based. So if it's too hot out, they like to hide. If it's too cold, they sleep. If it's warm, they like to lay out in the sun. And if it's raining, they like to get something to drink. And so, you know, they like it out when humans like it out. That's just kind of the simple takeaway from it. So again, they kind of function as this ambush predator. When they strike something, there's this sequence of events. They strike it, they release it, they track it down, and then they eat it. And functionally, what venom really does is it immobilizes prey. There's some other things that it may or may not contribute to, but functionally, that's the thing it has evolved to become incredibly good at. So what is snake venom? Like, what's going on with it? Why does it do this? And so it gets a little bit complicated when you kind of dive into it. So these are kind of the major overarching classes. And then within each class, there's a whole bunch of different compounds that have been identified. So there's over 100 different pharmacologically active compounds that may or may not be present in snake venom. Typically, it falls into one of these two groups, where either it's an enzyme that's kind of facilitating something happening, or it's non-enzymatic, and then it kind of disrupts endogenous cell signaling. It might be intracellular, it might be extracellular things, it might mimic endogenous things we have floating around. But it gets a little bit difficult to tease out because you have all these things that may or may not be present, and then a lot of variation with regards to what is specifically present within one snake. So even within one snake throughout its life, its own venom composition changes, making it a bit difficult to study, and then even more difficult to kind of predict what's going to happen for someone. Big takeaway that we have from clinical evidence is that you see a dose-dependent toxicity, meaning like most other toxins, the more toxin you have on board, the more clinical effect that you see. And so things that result in larger doses of venom being deposited typically result in worse clinical symptoms. There's a bunch of clinical evidence looking at venom levels and worse severities kind of supporting that. Making it even more complicated is that a lot of what venom does is it hijacks our own endogenous responses. And so you get this amplification, and a lot of the tissue damage specifically is propagated by our own endogenous immune response. And so this is how you can get a tiny little baby rattlesnake with a little drop of venom that causes a whole bunch of edema all the way up someone's, extremity, all the way up their leg in that case, up into the groin, or even in a hand bite, it might go into their torso. Beyond the tissue damage and kind of hijacking that stuff, the other big thing that we see here in the Southwestern US is we see this venom-induced consumption coagulopathy. And so overall, venom is usually rather procoagulant. It kind of forms a clot, although it does it similar to DIC and where it consumes clotting factors, and then you get this hypocoagulability as a end result. Now, most people don't develop clotting problems. It's a very rare kind of finding in snake bites, whereas the hypocoagulability is pretty universal in rattlesnake envenomations. And so even though there's a whole bunch of stuff that could be going on, what we see typically focuses in on this one little step where thrombin-like enzymes, which are one of those kind of enzymatic venom toxins, facilitate this conversion of fibrinogen into fibrinopeptides A or B, but they do it in different amounts than we normally do. Usually it's very predominantly one or the other, and so it kind of makes this mismashing mesh, and then the fibrin mesh doesn't stick around, it rapidly degrades. And so you end in this consumption of available fibrinogen and this clinically hypocoagulable state. So that's as nerdy as I'm going to get about venom toxins because I don't want to put my audience to sleep here. So we'll kind of touch on some snake basics, some snake myths, and some of those things. It's usually I poll audience, who would you rather be bit by? And so we kind of put this little baby snake on the left and we put this larger snake on the right. And every time I give this talk, someone will say like, baby snakes are worse. They're, you know, I definitely would rather be bit by the giant one. And I always say there's no way in the world I would rather be bit by a giant snake because again, dose-dependent toxicity is what occurs. And so if we look at how much venom you get from an adult versus a baby, you can see the adult on the right and you can see the baby on the left. I think this really kind of emphasizes what you're going to see. So again, I would personally always take the baby snake over the adult snake. The big difference between the two is that the composition and the amounts of different things within the venom change. And so adult snakes have a whole lot of digestive enzymes because they eat different things, bigger things, because they're bigger. And so you get a lot of tissue damage with any large snake bite. You may have some very remarkable sick patients with baby snake bites, but again, worse toxicity with larger snakes, and there's growing evidence to support that. So kind of keep on going and enter rattlesnakes and how things can happen. We like to address some rattlesnake behaviors. So for anyone that hasn't picked up on it yet, there is a snake in this video. This is a patient this year that agreed to let me use this video for educational purposes. And so if you look in the bottom of the screen in the middle of it, you'll see what looks like a stick, and that's actually the snake. This footage was captured using a ring cam. So dad walked past the snake, triggered the camera, and then he's going to go in the house. And then we're going to watch anxiously as we find out who amongst this family ultimately ends up getting bit. So we have our dog walking past. And now, of course, this is a PEDS conference, so now our kid is walking past. And then our dog walks past again, and ultimately it was mom that scared the snake. I use that video to kind of emphasize snake behaviors. Every year I have patients that tell me that a snake chased them, that a snake attacked them, and that they're these kind of vicious monsters that are out there, and that's not the reality. The reality is that they're quite terrified of us. Their first defense is without question to just lay immobile and wait for us to go away. If they get scared enough, then circumstances might change and they might feel the need to do this kind of defensive strike. So again, we kind of cover a bunch of the basics in this talk, but snake behavior, snakes are not aggressive by nature. There is no benefit for them in any way, shape, or form to bite something as large as us. Let's kind of keep moving forward here. So who is the Arizona Poison and Drug Information Center? Because not everyone is as familiar with what poison centers are. So we're a branch of the Department of Health, government agency, and then we collaborate with a whole lot of other folks. So our center here, we cover 63 hospitals across 14 counties, and then we collaborate with a whole bunch of folks around the state. So it's more than just us for sure. And us and our role in snakebite research. I always like to give folks some background on this. So a couple of years ago, we started this large snakebite registry development project. And, you know, the reason for this is that in this century, we've gotten a little over 4,500 cases so far in our records that we've been consulted on. And for comparison, if you look at all the phase 2 and all the phase 3 studies for Crofab and Anavib, combine them together, it's a whopping total of only 156 patients. And, you know, news alert, like we contributed to all of those studies as well. So those patients are also in our 4,500 patients. It's really difficult to get evidence-based medicine when it comes to rattlesnake envenomations. And so we've kind of taken up the mantle of trying to get better information out there, so to speak. So just some background on who we are and why I'm here talking about this today. Some other stuff, because I got to throw some shameless plugs in. So we do have a newsletter entirely dedicated to envenomations. I'm the editor for the newsletter. And in the newsletter, we try and address clinical topics that people run into when treating patients that you could ask Dr. Google all day long and you're going to have a really hard time finding it. So just a couple of topics that we covered, you know, recently. We covered pregnancy and envenomations. We've covered breastfeeding and envenomations, about when to restart breastfeeding, whether or not you should hold it. We talk about treating clots in active envenomations. We talk about treating bleeding in snake bites. A lot of these clinical problems that come up that, again, just don't have published guidance on, we've had to deal with. We've looked back at the cases, kind of critically decided on the outcomes that we got, and have some ideas about how to go forward with it. So again, that's just my shameless plug on it. So we keep going forward here. Another kind of polling question to the audience is, who does everyone think is most likely to be bit? And this is a good one if folks want to throw in to the chat there. So I've got 3 different demographics here. So cute little kid in the front, or at least I think she's cute because I'm a bit biased because she's my current 4-year-old. Representing our Peds exploratory kids, I've got the gentleman in the upper left who is a YouTube star that kind of represents one demographic that's historically been associated with snake bites. And then in the upper right is kind of our geriatric retired group. So usually I poll audiences for this, and usually I get a mixture. Some folks will say it's the gentleman in his 20s. Every now and then some folks will say it's the little kids wandering around. I mean, my kid, I love her, but she licked dirt for the first couple years of life. She just had some interesting habits. So picking up something that she shouldn't, I can clearly see her doing. And then usually some folks will pick the geriatric folks. And so based on our experience in our 4,000 plus cases and kind of looking through stuff, what we really find is that it's our 60 plus crowd. A lot of folks that end up getting bit are really retired. They're in their backyard and they're gardening. It's probably one of the more dangerous hobbies, so to speak, for folks to develop. And this has been an increasing trend over the last 25 years, where the average age was probably in the 40s 20 years ago. And at this point, the highest single 10-year demographic, so looking at like 40 to 50, 50 to 60, 60 to 70, is now 60 to 70. And it was a pretty steady trend up over the last 25 years. So other circumstances about when snake bites happen. Because again, if you live in this area of the country, this is kind of a reality, and so it's relevant for everyone. And so another kind of when folks think this is likely to occur, kind of break it down into the early morning, midday, mid-afternoon, and then overnight. And what we see is that really this 4 to 10 o'clock at night, or really more of a like 4:30 to 7:30, if I was going to be really narrowing it down, is when most bites occur. Also, most bites occur at home. We found about 60% of bites actually occur at someone's residence. We get a lot of folks that are concerned about snake bites, and they typically will talk about hiking and not wanting to go hiking because of that. But most bites are occurring when people aren't really aware of their situation. They aren't looking for snakes. We have probably about 10% of bites where they actually occur within the patient's house, where something like this snake under a bed or under a dresser is the circumstance. Just setting some numbers on it that kind of help folks recognize when things are going on. And then we kind of talk about what time of year to expect it. So living in Arizona and being from New York, it is just permanently hot here. I don't think it's ever cold, but the native Arizona folks don't necessarily agree with the math. So if we kind of break it down based on the big things that we see here, it's cold from October to March, according to the Arizona natives. April through June is this miserably hot and dry period. And then in July to September, it becomes hot and humid-ish. And so kind of looking at when we would expect to see snake bites, most of them really occur when it's hot and wet out during this July to September timeframe. And August is without question our highest single month year after year. And when we kind of dive into this, what we really found is that it has a lot more to do with birthing seasons and breeding seasons. And so we see a lot of birthing as well as a lot of breeding. So you have adults going places looking for mates, and you have a lot of baby snakes trying to go find their own place in the world. You also have a lot of humans that are out and about at the same time because the rains kind of bring some cooler weather at points. And so we get this kind of Swiss cheese model of humans and snakes being out places where they aren't always at, and then they encounter each other. So how are circumstances different in kids versus adults? And so the biggest difference, most bites are still going to be during the evening hours during the same 4 to 10 time frame. However, upper extremity bites are a whole lot less common. Most kids are getting bit on the lower extremities. Most kids are not seeing the snake or not recognizing the snake is there or with some type of a risk. Usually they're just kind of rampaging around and not even considering looking for something like that. And so the majority of our kid bites are what you would consider as a legitimate bite, which really just means that they didn't see the snake beforehand, as opposed to adults where upper extremities have a much higher rate. And so just in the kind of general interest of I don't want anyone in my audience to ever be one of our patients, we kind of advocate for situational awareness. Don't put your hands and feet places you can't see. Keep your house closed up. Don't leave your doors open. Leave your garage open. And if you happen to see one, leave it alone. Because again, 60% of bites happen at home. And a lot of bites would be preventable if people made different life choices. Despite me putting messages like this out there, folks tend to not listen, and then we have a steady supply of patients year after year. So should someone get bit, we'll kind of touch on pre-hospital care basics. All of these things are out there. There's papers, people have looked at them, people have suggested it's wonderful, people have suggested it's terrible. And so kind of a current understanding about what you should expect benefit from, looking at like tourniquets, icing, pressure bandages, cutting it and sucking it, which is what the Boy Scouts advocated for a whole bunch of years. We don't really recommend any of them. They tend to all make the tissue injury worse, which is probably going to make the morbidity and the recovery of the experience much worse. So we don't recommend any of these things at this point in time, and it's been that way for a while, although year after year, we still have patients that do most of these things. Electricity is a little bit less common, but there was a period of time where there were some tasers being marketed as a way to denature the proteins within venom as this immediate EMS type of treatment for envenomations. Didn't work, isn't recommended. This gentleman, however, tried it anyway, and stuff like this occurs. So he hooked himself up to the car battery, kind of had a friend rev it up a bunch as a way to kind of treat his snake bite, so to speak. Didn't work. We don't advocate for it, but we do still see things like this every year. Instead, we just say that self-treatment is never going to be an option. Dry bites aren't going to be diagnosed at home. So once you kind of recognize that you got to come into the hospital, you know, how do you diagnose a dry bite? Because you kind of end up in this situation where you got these things. You might have scratch marks, you might have punctures, or you might not have either. Might have a questionable history, and so you're kind of sitting around waiting for something to go wrong, so to speak. So let's look at what you should be able to expect as the kind of so-called typical sequence of events. Again, venom composition is highly variable, and so this is the range of what could happen. Any patient may have some of these and may not have others. Some patients might have all of them, but the timing of events is pretty consistent if they're going to occur. And so early symptoms that we see, and these typically start in the pre-hospital setting, are caused by small molecular weight venom components, things that keep the venom inactive within the snake's venom gland that stops it from auto-degrading the gland itself anyway, will change the local pH and allow that venom to become active. They also kind of get rapidly absorbed, and clinical effects are sometimes apparent. And so GI symptoms are fairly common. Hypotension that may have reflex tachycardia intact, or it may have bradycardia. There may be some of these systemic neurotoxic symptoms where you might get metallic taste changes, paresthesias. You might get some neuromuscular excitation in myokymia or fasciculations. Laboratory abnormalities in the coagulopathy are typically detectable in the early phase. And so these things typically happen. They start in the pre-hospital setting. By the time someone gets to the ED, if they're going to be there, they're usually there. Coagulopathy being the one that may still not be apparent for a while, and that's kind of based on the way that we define it. Because you have to get a measurement below a certain threshold where you're not necessarily picking up on the fact that it's being consumed and is downtrending when you're getting your first labs. But the effect is clinically occurring during that period. So if those things are going to happen again, those are typically starting in the pre-hospital setting. some point after that, this local tissue damage will start to happen. Because again, snake venom is primarily a bunch of digestive enzymes and then things that can immobilize prey. We typically are far too big to be considered prey, and so the clinical effects that we get are a lot less severe most of the time. And so this tissue damage will usually start within the first couple of hours in the majority of patients. There are some rare cases where it seems to have a more prolonged onset. In the most remarkable cases, this is somewhere between like 10 to 12 hours. And so the most conservative dry bite times for like observation go for about 12 hours. A lot of folks don't necessarily wait entirely that long. You should see symptoms in most patients by about 6 hours. And again, the idea behind this is that venom is inactive in the snake's gland, and while we might assume that it becomes activated when it gets deposited, there is a reasonable basis that it might not be, and so that delayed onset of effects does occur sometimes. Minority of patients for sure. Once that starts, you'll start to get all the local effects that you would see, so pain, swelling that might result in kind of some ischemia distally to it. You might start to get some local paresthesias. And then local kind of necrotic tissue that might start as blisters and blebs might form. We see about 30 some odd % of patients develop blisters and blebs. That is going to kind of start within the first couple of hours. And then this slower process of the lymphatic absorption of these larger molecular weight compounds will start to occur, and they travel up the lymphatics. And so we'll see lymphangitis somewhat frequently. Lymphadenopathy is super common. And then when the necrotic wounds start to kind of develop, an infection, if it's going to set in, is going to set in with a delayed onset. And so these kind of occur over the first couple of days. And if we think about the acute phase of an envenomation that comes in and gets antivenom, it's probably about 48 to 72 hours by the time most of this stuff is hitting its peak effect. Notably, there are some other effects with a bit of a delayed onset. And so we get this widespread damage to the vasculature that results in this ecchymosis that occurs. So you get some localized bruising around the bite site, but this very specifically is talking about non-contiguous from the bite site, and so you see it in other areas, and I've got some pictures coming up shortly. If folks are going to develop bleeding complications, they typically are also not in the acute phase. They're usually starting out a couple of days afterwards. So if we're going to look at lab diagnosis, these are kind of the current accepted criteria. And again, the role of these things in this setting is really just to serve as a venom surrogate to say that venom is there, and thus there is this kind of potential benefit for antivenom. So fibrinogen or platelets less than 150 or an INR greater than 2. They all have limitations though, so there's all reasons that they might not be accurate. So fibrinogen is indeed an acute phase reactant, and so we see hyperfibrinogenemia in a bunch of patients if they have an infection. Snake venom doesn't necessarily seem like it always trumps this, and so that might be clouded. We have a bunch of reasons that folks might have baseline thrombocytopenia, and so platelets aren't definitively reliable. And then again, we have therapeutic reasons that folks might have an INR greater than 2. So you kind of got to keep this in mind when you're looking to diagnose folks as to what their baseline status is. And then we can start to look at clinical diagnosis. So in emergency medicine, we kind of use this phrase, or at least some of us do here at least, about the 3 P's of death. So puking, pooping, and passing out. It's kind of a bad risk factor for folks coming to the ED. It holds true in a bunch of different exposure settings, and it holds true in our rattlesnake bites. So again, kind of some dramatic pictures just to kind of help remember, like, these are the things that are associated with fatal cases, which, although they're rare, these symptoms are pretty universally there. After those, we'll throw some pictures and some other things. So this is looking at the neuromuscular toxicity. I'll see if I can get this to start playing for everyone. Oops. Whoa. Sorry about that. Some technical difficulties here. Let me try and get it back up. least my video is working now. So when we're talking about neuromuscular excitation, these are a couple of videos that we've taken. And so you see these kind of like fine worm-like movements in the legs and that gentleman's lips. And then this is an ultrasound. So the ultrasound is showing what was subclinical myokinia. Externally, you couldn't see anything, but then we were able to pick up on this on ultrasound. And so one of the complications, if you see neurotoxicity, this is what it typically looks like. A bunch of the kind of local tissue damage that we see. So we see a whole bunch of erythema sometimes. We see a bunch of swelling. So we've got some pictures of that. And some of the blisters and blebs can look like a bunch of different things. Sometimes there's a bunch of small ones traveling up a limb. Sometimes they're kind of big and large and stick in one little area. We do occasionally see infections. So this one is a case from last year. It's a little kid that ended up developing osteo after a bite by a snake in their house. And then with regards to bruising, we see two different types. And so we see kind of the really extensive bruising on the left, kind of going from the patient's hand all the way up into their arm and then into their back. And then this lady happened to be gardening. And this one we had pictures, they're about 4 hours apart to give you an idea of how extensive and rapid the bruising can be when it sets in. And then by contrast, this is the delayed onset bruising that I was mentioning. So this is the same patient, same point in time, and you can see where the bite location is all the way on the left. You can see her leg and the swelling that was occurring. And then you can see where the vascular damage and the bruising actually occurred. And so this one happened to be on the back of her thigh, but we have patients that'll develop it in their back, in their armpits, a lot of different places that are quite regionally different from where the envenomation is. So this takes a pretty thorough examination to look for this when you're looking for it. Thankfully, our treatments are somewhat easy at this point in time because antivenom is really the only thing that we have. There are some supportive care things and the roles of those are kind of debated. So I'll be pretty superficial about what I talk, although if folks have questions, I'm more than happy to dive into them when we get to that point. Different products that are out there. So Wyeth, the one in the middle here, was the original, the whole IgG. It was around for a bunch of years, about 50 years. And it was kind of the first FDA-approved drug that was widely available. Had a whole lot of allergic reactions associated with it. And it really led to a very cautious use of antivenom. You had to be sick enough to warrant antivenom because the antivenom brought its own harms and risks of harms with it. In 2000, however, CroFab came out, and it was this Fab fragment that kind of removed this equation of hypersensitivity reactions. It has much lower rates of adverse events. The safety profile is significantly better, and so widespread antivenom use and this concept about giving antivenom early and in adequate doses kind of started to be first implemented in this country, which isn't that long ago. It's still this century. And so that kind of changed practice, although folks having a very conservative approach to administering antivenom still occurs today in lots of parts of the country, arguably not based off kind of accurate evidence of risk-benefit scenarios for patients. But either way, CroFab came out. CroFab brought its own kind of complications of this venom recrudence effects, where venom effects were observed again a couple of days after antivenom had been administered. Idea being the short half-life of CroFab was the basis for it. And that was kind of used by RDT to get Anavip approved. And so Anavip comes out, it has a longer half-life. We indeed don't seem to see the same type of late or delayed coagulopathy complications we do with CroFab. And CroFab and Anavip are the two currently FDA-approved products available for us. So if we're looking at the two kind of side by side and we look at how do you determine when to administer antivenom, and again, I'm just going to keep this rather basic. Initial control, the definition we use and one that's in the literature is kind of looking for progression of edema less than an inch an hour. If it's traveling faster than that, it seems like there is a reasonable benefit for the patient in administering more antivenom, and that's been used as an indication to give more antivenom for quite a while. We also track fibrinogen levels and make sure that they're not worsening. That's kind of our local practice. And then you've got your kind of loading doses, maintenance dosing for CroFab. Some places use it, some places don't. Again, in the land of shameless plugs, however, we strongly just advocate folks call poison control. For us here, we consult on the vast majority of cases in the state. And so we can provide the most up-to-date evidence-based information that we have. But it also is part in the role of public health reporting on a rare disease. So this is indeed considered an orphan disease just based off of numbers. And by reporting to poison control centers, this allows us to gather data on something that's rather difficult to gather data on. So even for the folks that aren't necessarily looking for clinical advice on treatment, we do still encourage folks just to go through the motions for the sake of reporting. Beyond antivenom, the other things that come up, you can get hypersensitivity reactions. These may be from the venom. They might be from the antivenom that we're administering. Life-threatening bleeding is a rare event, although it does occur. There is a role for antivenom in some situations. There's a role for transfusions in others, and we'll talk about that in the upcoming slides a little bit more. Wound care is probably one of the most underreported and under-recognized complications. There's some folks that we've been partnering with in Alabama that have been helping to expand on this. Where a snakebite clinic was recently formed. Pain management is another big thing that we like to kind of remind folks of. So we here have been recommending for a while of using fentanyl as to avoid the histaminergic effects of morphine. Whether or not that's applicable outside our borders may or not be the case, but we seem to find lower opioid requirements in folks that are getting fentanyl. And if fentanyl isn't working, we typically will switch over to giving some benzos as well as an adjuvant. So just some kind of things to keep in mind for the sake of the realm of supportive care needs in a snake bite. This is a bleeding severity criteria that we developed a couple of years ago. Here, it's just based off hemoglobin levels, based off trauma literature. Our thresholds are somewhat conservative, but we're factoring in that our patients have a hypocoagulable state most of the time. And so we break things down whether or not it's a spontaneous bleed versus a provoked, because obviously if you have an injury to the vasculature, that's all you need to bleed, and then we can identify it versus a spontaneous bleed is kind of this thing that we're most concerned about. So we did this rather large internal review and kind of looked through our records. And what we found is that you don't really see a lot of bleeding. So we found 1.2% of our cases developed a spontaneously generated bleed where the hemoglobin level dropped all the way below 8. Whereas the majority of patients, or 85+% of folks, didn't develop any signs of bleeding beyond just kind of some localized bleeding from the bite stuff that we don't really deem adequate enough to be bleeding, mostly because it's a fairly universal finding in patients. And so for us, this really kind of emphasizes the concept of you have this consumption coagulopathy, but you don't necessarily have enough vascular injury in most patients. Just kind of, again, just touching on some of the big things that kind of come up, because this is a short time frame to cover a large topic. So once you kind of address the acute phase, this kind of discharge the patient and then go into the outpatient subacute phase comes up. So the criteria that we use and are looking for, we want the acute toxicity to be resolved. So we want that progressive edema to be completely halted. We want it to be stable for a number of hours. We like to see the fibrinogen greater than 150 and the INR less than 2. Obviously, you might have exceptions to that if you have patients on Coumadin, or again, infection patients might have a rather large fibrinogen, but there aren't a lot of reasons for someone to have baseline hypofibrinogenemia, and so it's a rather reliable marker of envenomation. And then the other big thing that we advocate for is a clear plan for the recovery phase. So pain control, inadequate pain control is the leading cause of people returning to the ED in what we've seen. So, you know, we have them come in, we treat them, we give them their antivenom, we send them out, and then they don't have access to IV opioids anymore. They still have a bunch of tissue damage, they have a bunch of swelling, they have a bunch of pain, they're going to physical therapy, and they have nothing but Tylenol, and folks are telling them not to take ibuprofen. So again, pain control is the leading reason we see people come back to the ED following a snake bite. We do pretty strongly advocate for physical therapy and occupational therapy involvement, because once the envenomation part of this has been taken care of, this is just a traumatic injury. And so all of the normal concepts about recovery from any other type of mechanical injury should be in place. And this is one of the things that we're very actively studying right now. For the folks that are developing any type of necrosis, some type of wound care plan may need to be in place. We service a lot of very remote locations where access to healthcare is a major problem. And so we like to make sure that we have all of this stuff buttoned up before folks are leaving the hospital. And then again, in our land of shameless plugs, poison centers, provide this free service to patients to coordinate all of their outpatient care. So We did a study here that looked at the last 5 years, compared our records with hospital discharge data. We found that over 99% of folks in the state that got antivenom, we were contacted on. So we take that as a good mark of success. But the biggest reason that you really have to kind of benefit from this is that the patient gets this free access to care outpatient, and we can kind of help them navigate this murky water during the subacute phase. So I usually pause here to get a chance for folks to ask questions or anything like that. But it's kind of ending the quick overview of this large topic. And so then I kind of transition into a case that's a bit of a complicated one to see how well folks can kind of apply things. So this is a real patient. He drove himself to the hospital 5 days after being bitten. You can see the bite site on his hand. You can see that non-contiguous bruising. The only reason he chose to come to the hospital is his testicles started to swell up to the size of about a grapefruit. We have pictures, but I spared you guys that today. Likely filling with blood based on the color of them. And so his initial labs at presentation, his platelets 7,000, his fibrinogen below the detectable threshold, and his hemoglobin was 4.6. I don't know how he drove himself to the hospital, but he did. And so I usually throw some questions to the audience to kind of think about. So does he have a coagulopathy? It's kind of a yes or no question. And then is he bleeding? And the answers to those questions kind of help identify the next question. So does he need antivenom? Is there potential benefit to him? Does he need a transfusion? And so usually I'll kind of go through the audience and pick at folks. And most people will say yes to everything, and then they miss kind of my curveball trick question that I like to throw in here. So he actually didn't have a coagulopathy. His INR was normal. Now, bear in mind, if he received any type of mechanical injury, he probably would have bled like a sieve, but he was maintaining normal hemostasis, so to speak. And anything that assesses coagulation is going to pick up on that. So it might be a PT-INR. You could probably get it tagged reliably, look for abnormalities there, but his ability to form a clot is still going to be measured by that. How much of an injury he could sustain before developing bleeding problems is going to be based on his available pool of clotting factors, which is what those numbers behind platelets and fibrinogen are really telling us. And so moving on to the next question, was he bleeding? Probably. His testicles were filling up with a bunch of blood. And so roles of antivenom, roles of a transfusion. And so another thing that will come up when I give him this talk is some folks will say that there is no reason to give him antivenom. We disagree with this kind of prospect because if you look at the synthesis rate for fibrinogen, fibrinogen is made on a time scale of hours. And so if he has an undetectably low fibrinogen level, you know that active venom is having an effect within the last 6 to 8-ish hours at most. And so I would argue that there is potential benefit for the patient administering antivenom. We routinely see fibrinogen levels turn around following antivenom within our OBS period, which is usually Q6 once they start to get stable. And then the kind of simple no-duh question about does he warrant a transfusion is, yeah, he's got a hemoglobin of 4.6. So antivenom isn't going to fix any type of anemia-related complications. The big mix-up and confusion around this is that some folks will transfuse based on coagulopathy labs, which don't really correlate to bleeding. And some folks will just give antivenom and kind of ignore the fact that your patient is bleeding all over the place. And so we really kind of emphasize the role of both and the timing sequence of when you want to give them. So some kind of pearls of wisdom to sum up this large chunk of information I'm throwing at everyone this morning. We strongly advocate for not delaying or underdosing antivenom. You got to match a dose of venom with a dose of antivenom to neutralize clinical effects. I report our averages here within Arizona. They are likely not universally applicable outside of Arizona, but this is what we see. So our average patient getting ProFab has been treated with 15 vials, and the average Anabit patient has gotten 18. We like to emphasize that antivenom won't reverse venom, right? This is not a Hollywood type of cure where you give the antivenom and then they magically are, going back to saving the day in some action movie. Like, antidotes don't work like that. For the most part, antivenom is no exception. All it can do is stop the venom from causing more damage. All of the damage that has already occurred is going to still be there. And again, that's kind of the basis for not delaying administration of antivenom. If you wait and watch a whole bunch of tissue damage occur and then give the antivenom, the question kind of comes up, well, what are you really trying to treat at the point you're giving it at that point? Regardless of the time of antivenom, Administration from the time of bite, we usually see peak edema occurring about 48 to 72 hours post-bite. The idea behind this is that a lot of the tissue damage is the own endogenous response, something that's not going to be impacted by antivenom, right? So the antivenom is just going to bind up to the venom that's floating around, but all of our endogenous mechanisms that are propagating that tissue damage are already started, and antivenom isn't going to stop that. Another thing to keep in mind is that you're going to have to synthesize clotting factors. So if you stop the consumption of the coagulopathy, that's fantastic, but knowing the time scale that things are synthesized is very important for trying to interpret your labs when you're getting them. So fibrinogen is going to be synthesized relatively fast, where platelets are more of a time scale of several days. We do see some kind of pro-aggregating and anti-aggregating phenomenon with venom, and then a dramatic change post-antivenom. So a very common thing is platelets will be 13 when people come in, you give antivenom, and now all of a sudden they're 250,000. Folks like to pat themselves on the back and think that everything's better at that point, but typically the INR is getting higher and the fibrinogen is going down in those patients at the same time. If venom is around long enough or the right things are there, the platelets will be destroyed, and then you're going to need several days to synthesize more. And so there are cases where folks have gotten 50, 60, 70 vials of antivenom essentially in an effort to grow platelets and treat a number, and it doesn't work. So at some point, you kind of have to recognize that antivenom isn't going to fix everything, and that there's a very real likelihood that some platelets will be destroyed, and you're not going to necessarily grow more by just giving more and more antivenom doses. And then kind of our personal soapbox here is we really like to emphasize that snake bites are a traumatic event. And so one of the underrepresented things in the literature is that the recovery of snake bites is not what a lot of folks had assumed. A lot of folks, myself included as a fellow, assumed that most people were better within a week or two. And the reality is that a lot of folks are still having functional impairments, a range of motion complications, edema complications, pain complications for 3 to 6 months post-bite. Some patients are certainly developing chronic problems that are expanding past a year. And so this is a very active area of snakebite research for us and some other folks around the country, trying to get a better idea of what the morbidity-related outcomes are, especially in the functional impairment realm. Another thing that we've been exploring is the psychiatric sequelae. So as I mentioned, the leading location people get bit is their home. And so, in the scope of peds envenomations, the little kid that had osteo, she got bit by a snake that crawled out from underneath her dresser at 11 o'clock at night. How do you go back to that same bedroom where this event occurred? And that kid was in the hospital for 56 days and left on crutches. That's an enormously traumatic event for her. I have other cases of some kids that got bit while they were trying to pee in the middle of the night, and I joke when I'm giving this talk at times, but I would probably pee the bed for the rest of my life as a little kid that got bit while trying to go to the bathroom at 11 o'clock at night. There's no way. And so we've really been expanding the awareness on this over the last year, and we've had a few patients actually get diagnosed with PTSD since we started this. We suspect that, again, this has probably been occurring the whole time and is dramatically underrepresented. And then the financial impact, which usually the news does a good job of kind of trumping this up, but our average snakebite patient, the hospital bill is around $110,000. And then the patient's responsibility of that has ranged anywhere from less than $500 to up over $25,000. And we have some select cases of folks that have had to sell their house, move in with their parents, and this becomes a hugely traumatic event in all three arenas, right? They have these physical complications. They might not be able to work the same way that they used to. They have this stress and anxiety that they're developing. And then you throw on this crippling financial burden where they lose their house. And one simple event like taking the trash out or going to get their mail has essentially, quote unquote, ruined their life for this long stretch of time. And so we're doing a lot of advocacy to try and spread awareness on this topic. And then again, just kind of a little dramatic case to kind of emphasize that this does indeed still occur. So this poor little kiddo got bit. Her dad got her into the hospital in under an hour. The antivenom was withheld because the patient's symptoms were deemed minimal. Likely what was going on is the venom wasn't active yet. And then there is this very dramatic and profound onset of clinical toxicity where she all of a sudden became too sick, and the need to transfer her became very apparent. And so then she was transferred. Ultimately, she didn't get antivenom until about 8 hours later and then ended up dying. So very unfortunate case. The parents chose to use her example as a way to spread awareness, which is why I'm using her case today. But the point being, again, that this still occurs. A lot of times when this occurs, it results in legal suits, and then those things get sealed behind records, and so we don't necessarily hear about it. It's harder to find those cases, but this still happens. There are still a handful of deaths every year where if the kid had gotten antivenom, I would say that her chances of survival would have been dramatically higher. So after throwing all this info at you and trying to stay on time, I'll open it up to questions, however I can here.
Dr. Smelski, that was awesome. Thank you so much. Are you able to see the questions in the chat?
I can try here.
So one of the questions, someone is asking if you see more snakebite cases from rural, remote areas, or does it seem to happen in the city as well?
Yeah, great question. So the snake encounters in rural areas might be more frequent for an individual, meaning that you might see more snakes per year, so to speak. But the number of snake encounters total and the number of bites is actually much higher in urban areas, just because it's a two-piece equation, right? You need snakes and you need people. And so we actually see more urban bites than we do rural. The delay to getting care and then kind of access to care and the complications of that are much worse, and outcomes are worse for patients living in a rural setting. But numbers-wise, we see a lot of urban ones, and it's most likely just related to the expansion of the city. So we cover the Tucson area, which is in Pima County in Arizona, and it's a very rapidly expanding area. And so anytime you start expanding into the desert, you're just taking over their home, you're disrupting stuff, and then snakes go places trying to find a new home. And so in areas of new construction, especially, we see quite a few bites.
Thank you. And then another question is, what is the best or optimal thing to do immediately after you have been bitten? And kind of a follow-up to that, is there anything homeopathic that you can use?
Yeah, so as far as best thing to do is you want to get into a hospital. So you have this very short golden window of time where no symptoms have necessarily started to develop, but they're going to start to develop and they're only going to continue to get worse. And so your best thing to do is get to a hospital. And I love giving this talk to the EMS folks because they try and craft this fantastic, impossible model of where I advocate for crazy things like tourniquets and stuff like that. Is this, doomsday scenario I always pick on them for saying, where like, if you're 3 days out from having a cell signal to call someone to get a helicopter to get to you, sure, maybe there's a role in a tourniquet. And I always tell them, like, I still wouldn't do it. Your definitive answer is going to be to get to healthcare, because if you need antivenom, it's the only thing that's going to work. Not everyone that gets bit ends up with an envenomation, and not everyone that ends up with an envenomation has a life-threatening envenomation. But you won't ever know it until it's far too late to do something about it. And so as a person that's been bit, your number one goal in life should just be to get to a hospital as fast as possible. If that means you're out hiking and you need to walk yourself, then it means walking yourself. You don't have to walk and can get picked up by EMS. That's ideal because it doesn't mobilize the venom. So if you look at international literature, having to walk a distance greater than a quarter mile is actually associated with increased mortality. And it likely just has to do with facilitating venom absorption, leading to more systemic and then again, dose-dependent toxicity being present. So if you're able to just call EMS and be picked up, that's ideal. Even if you're in the wilderness, you want to start hiking back out to somewhere where you can get picked up by EMS. As far as homeopathic things go, again, the only effective treatment is going to be antivenom. There may be a role for things that out there, they have never been studied. Again, this is an orphan disease. Even the evidence supporting the antivenoms is pretty minimal. The only real thing that they proved was the antivenom doesn't kill someone, and that there was a change in coagulopathy labs with a temporal correlation that suggested the antivenom was the cause. But there's no outcome difference, right? Mortality wasn't different because mortality rate is less than 1%. There was no morbidity outcomes actually even reported in the studies. And those are the ones that got the drugs FDA approval in this country. So you could certainly try things. I usually advocate against it because it's only going to muddy the waters, and I don't have any reason to suspect that they would be beneficial. Doesn't mean that it wouldn't be worth studying if someone wanted to design a study and try and answer that question better.
And then this another person is asking something that kind of in a similar vein. If you're going out hiking or backpacking on a long-term field trip, I think is what they're saying. What supplies should you carry in case you have a snake bite?
So, if you wanted to be the most, self-sufficient in a disaster scenario, like having something like a satellite phone where you would just be able to call someone no matter where you are and provide them GPS coordinates, just as a way to facilitate getting to a hospital as quickly and easily as possible should something happen.
Absolutely.
You're not going to want to treat it in the field.
Another person is asking if emergency medicine physicians have been trained to, they say, admit the patient immediately and use antivenom immediately. And this person says, usually in emergency departments, they keep people waiting for hours, and that is enough to cause fatal outcomes. I'm sorry to the question asker if you've had a personal experience that has been unfortunate like that.
So we do a lot of training here for it. So we train in person at the hospitals around Tucson. I go to several of them on a monthly basis, and I train a lot of folks in a bunch of different departments. We also do a lot of educational talks like this one where I kind of try and get our message out there. And so I can at least say for within the borders of Arizona, most of the time rapid administration of antivenom is the norm. The overwhelming majority of our patients are able to get into a hospital and start antivenom in under 4 hours, compared to, like third world where time to antivenom is usually measured in days. So I can say for Arizona, that's the norm. There are exceptions to that, and there are folks that are not as familiar that might not administer antivenom as rapidly as we do or recommend. Again, I don't advocate for it. And again, in the realm of risk benefit to the patient, if there's going to be benefit to antivenom, patient is much better off getting it early on. And if they're going to inherit the hospital bill of being treated, they may as well get their best chance for a rapid recovery.
Absolutely. And then I don't know where this question asker is from, but if you are from the El Paso region, I can say that as the medical director of the West Texas Poison Center, I do train physicians locally in multiple hospitals, but I just want to advocate, as Dr. Smelski has been doing too, it's always a great idea to call the poison center, or if you're bitten, ask your physician, please call the poison center, because medical toxicologists around the country and clinical toxicologists as well are the ones who are the specialists for this and can give a physician who might be less experienced in managing rattlesnake envenomation advice on how to treat the patient. I'm just going to go through the chat and see if we missed any questions. I think, well, another question, someone's asking if you would be willing to share your slides.
Yeah, I'm more than happy to share the slides. I don't know how to make that happen, but I assume you can make that happen for me.
Absolutely. Yeah, maybe just email them to me as a PDF and then we can disseminate them. Are there any other questions from the audience members? Oh, someone's asking, are rattlesnakes the only poisonous snakes?
So there's a bunch of different venomous snakes that are out there. For what I deal with in Arizona, rattlesnakes are the major one. There are still coral snakes, which are kind of in the elapid family, the cousins of the crotalids, so to speak. So it's a little bit easier for us here because the vast majority of what we see are rattlesnake envenomations. The coral snakes that we have here are really small. You pretty much have to be handling them and then get bit on like the webbing between your fingers because they're so small to have an envenomation, and most of the symptoms tend to be somewhat minor when that happens. When you go east and start to run into copperhead, cottonmouth, echistrodon country, you can get other envenomations that aren't rattlesnakes but are still in the same kind of crotalid family where they're not necessarily as identifiable because they don't have the rattle. And then there are an abundance of non-venomous snakes that look like them. And so one of the snakes in Arizona actually has a triangular head that people have believed it evolved to mimic rattlesnakes as a way to kind of avoid being prey from other things. So it's a little easier for us to identify, and depending where you are, there's going to be a different pool of snakes around.
And then I think we should wrap it up after this last question, which is a great one from Dr. Jimenez Segovia here. Are there any resources to help those who are bitten in terms of financial resources?
So at the moment, there are zero, although I am working with ADHS, so the Arizona Department of Health, to try and change that right now. And I doubt that there is anything in place in any other state in the country. I haven't heard of it if it does exist.
Yeah, I doubt it. Well, thank you so much, Dr. Smelski, for speaking today. And this was a great presentation. We're getting a lot of thank yous and appreciation in the chat. So please, if anyone has any questions, you can email us and we can forward it to Dr. Smelski, and we will be able to distribute his slides hopefully this week. Thank you, everyone, for attending.